I think we will move on to the next talk by Dr. Remya Edachery. She will be speaking on vision assessment and refraction in kids. Is it really difficult?
Hello. Yeah, good morning everyone. I know many of you are not pediatric ophthalmologists here. But any child can land up in your OPD. So you will be, that patient will be benefited by your guidance and appropriate referral is required. So my topic will be vision assessment and refraction in kids. Is it really difficult? I will be covering this under 4 headings: visual milestones, visual acuity estimation, and refraction in kids, and if time permits, a few practical examples as well. Coming to visual milestones, when a newborn child is born, the child blinks to light and the pupil reacts to light. And fixation to bright light and phases starts by 1 month of age. Fixation and following to accommodative target by 2 to 3 months. And the child recognizes mother's face by 4 to 5 months. Convergence, stereopsis, depth perception, color vision starts by about 6 months, and the rest of the visual developments are developed after that. So when a child is born, the visual acuity is around 6 by 240, which reaches to 6 by 6 adult level by 4 to 5 years of age. Coming to visual acuity estimation, there are an array of tests in children which recognition acuity, resolution acuity, and detection acuity. But I will be going to the most important ones which we do in our daily OPD. So I will be dividing into under 3 headings. That is pre-verbal children, 0 to 3 years. Verbal, that is pre-literate, that is 3 to 5 years. And verbal literate, more than 5 years. In pre-verbal children, we normally do resolution acuity. We do optokinetic nystagmus and force preferential looking tests and VEP. Whereas in verbal pre-literate children, you can do matching tests like HOTV and Lia symbols and K pictures. And verbal literate, as in adults, you can go for a Snellen chart or a Logmar chart. So this fixation and following, it should be done binocularly as well as monocularly. It's a qualitative assessment of vision assessment. So this is usually described under 3 headings: CSM, that is whether the fixation is central or not, and whether it is steady or not, if there are any nystagmoid movements, and if it is maintained. If you cover one eye and uncover, if the child is able to fixate the object properly, means continuously. So in this child, you can write it as central, steady, and maintained. Whereas, look at this girl. It's not playing. This one, first one. Look at this girl, even though the fixation is central, you can see there is nystagmoid movement, so it is not steady. Whereas the other child, the left eye is central, steady, and maintained. Whereas in the right eye, you can see when you cover the left eye and uncover, the right eye is not able to continuously fixate, so that is, it's not maintained. So according to the fixation pattern, you can have a rough estimation of the visual acuity. If the fixation is grossly eccentric, the vision is less than counting fingers. If there is unsteady central fixation, it's around less than 6 by 60. Steady, central, but it is not maintained, around 660 to 636. Central, steady, and maintained, but the child prefers the other eye, then around 624 to 612. And if there is a cross fixation and freely alternating, usually the child will be having a very good vision of about 6.9 to 6.6. This is how you roughly estimate. Coming to optokinetic drum, this is a drum with a dark and white stripes, and you will be rotating it. Then the child will be having a physiological nystagmus with a fast phase and a slow phase. So depending upon the gratings, reducing the grating, you can estimate the visual acuity. These are the tag cards. It consists of dark and white stripes on one side and a homogeneous gray area on the other side with a central peephole. So the examiner will be looking through the peephole and looking at the eye movements of the child. It is done at 38, 55 and 84 centimeters, and the visual acuity will be written on the back side of the card. This is how it's done. So the examiner will be flipping the card and looking at the movements of the eye. And if the child is able to do that, then we will take the next card and record the estimation. Similarly, you have the Lia paddles also. You will be flipping between the two hands and looking at the movements of the eye. It is written as cycles per degree. Then you have the Cardiff acuity cards. Here, what is known as vanishing optotypes will be there. So there will be a white band which is covered with a bordered with a dark line. So all the pictures will be having same size, but the bandwidth will be decreasing. According to that, the narrowest bandwidth with which the child responds will be the visual acuity. And coming to visually evoked potential, it actually tests the integrity of the visual pathway. So only till the occipital cortex it measures. So if the child is having CVA and poor vision, but your VEP may be normal, so you should be careful in those cases. These are the methods of estimation at different age groups by different methods. And coming to the pre-literate children, here you have the matching cards. So these HOTV and Lia symbol cards, these symbols and letters have a vertical symmetry. That's why we use these cards. And here you just give the paper to the child, and the child has to just match with the chart given in the chart. Then another is response to occlusion. This is also a rough estimate. In this child, you can see the child is fixing with the right eye when I cover the left eye. But when I cover the right eye, the child is resisting occlusion. That means that the child has a very poor vision in the left eye. Coming to refraction in kids, speed is the essence of pediatric eye examination. So whenever you get a chance to do your retinoscopy, you should be able to do it. Then only when someone comes, you can do it very quickly. So cycloplegia is mandatory in kids. We use these drugs, atropine 1%, hometropine 2%, and cyclopenrolate 1% in kids. You should make sure that inform the parents about the adverse drug reaction. And in case of squint, you have to occlude one eye, then do the refraction. Otherwise, you may get erroneous values. Especially in children with amblyopia, you may not be able to give the subjective correction depending upon your PMT. So your cyclorefraction values, you will be giving the prescription according to your cycloplegic value. Then these are the Bruckner's reflex. Here you can superior reflex if there is hyperopic, inferior reflex is myopic. Then these are the values according to the AOS and AAO guidelines. I will not be going to that. So myopia, hyperopia, and in a patient with a squint as well as in anisometropia. I'll just run through few practical examples. Here is a 4-year-old girl, uncorrected visual acuity 6/60, no squint, cyclorefraction is this much, but the child accepts only this much. So how much do you give? You have to give, for full value, you have to give minus 4.5 at 180 only. So don't give according to PMT. Here is a child with a 2-year-old boy, mother is myopic, no squint, cyclorefraction shows -1 diopter. But here don't give glasses, but inform the parents that the child is going to get the glasses in the future and explain about the measures to take to prevent the progression of myopia. Here last one, 1.5-year-old girl, inward deviation, 1 year, ET for distance and near, atropine plus 3.5. So here you have to give full correction because the child is having ET. But in a normal child, you may not have to give the glasses. So I would like to thank my teachers who were in my professional journey, Dr. T.K. Ramesh sir, Dr. Jyoti ma'am, and Dr. Chimay ma'am. Thank you so much.